problem. I don't think money's the problem. I think it's leadership. I think
Yeah. So
I don't. There's a shitload of money. We think it's $11 billion that goes into the state mental health budget. That's number one per capita in the United States.
And yet drug deaths are going up. 20,000 people were dying every year in the year 2000. Last year, 112,000 Americans died from illicit drug overdoses. It's an incredible increase, and you can just see it skyrocketing. 75,000 of those deaths were from fentanyl. If this continues, we're going to have 1 million people dead in a decade from drug deaths. We're all failing on this issue. In San Francisco, harm reduction programs such as GLIDE do not require staff to guide people toward treatment. It's even stronger than that. They prohibit people from guiding people towards treatment. They argue that such pushiness could scare away clients who are not interested in quitting drugs. They often cite the drug policies of British Columbia, a global leader in harm reduction, but British Columbia set a record for overdose rates last year. Narcan is the thing you use to revive people when they're overdosing. And people say things like, we saved lives. It's now clear that you're often just delaying the day of death, because what's happened is that, in fact, in San Francisco, you saw in 2020, we had a big spike of overdose deaths. And then in 2021, it went down a little bit. And the idea, I think that there's a lot going on, but I think part of what happened is we got a lot of Narcan out. And so there's Narcan everywhere. I was with the Times of London, and we saw a guy overdosing, and they all had Narcan like right away. But then you get to 2022, 2023, and the Narcan, after you've been Narcan 30 times, your fentanyl consumption, your tolerance is so high, it requires so much fentanyl to get high that the Narcan stops working. And so the people that are dying are people that are almost always being Narcaned, and the Narcan's not working anymore. So in that kind of a situation, I mean, I don't know how much more dramatic it needs to be. You would take if you can reduce the death toll by 1/3 or 2/3, you would do it if you would have that intervention.
Hi. So I think the sad other side to this issue is that, like, experience in the recovery community tells me that there aren't a lot of actual evidence-based treatments for addicts. You know, like you can go to a drug counselor and go to rehab and get on naltrexone and go to AA and all these things, and you'd still better get on your knees and pray that you're not like, you know, some 40% of people for whom none of those are gonna work. And I know that this is a moral argument, but I sort of hear that Housing First works for 12% of people, and I think about the percent of people that are probably never gonna get better. And I imagine putting at least some of them in the dignity of housing. And I think, you know, what's wrong with that?
Yeah, what's wrong with it is that that's where they die. So if they're in those rooms alone, they're dying. And what you get with the Birmingham model, the contingency management model, is they're in the dignity of congregate shelter. I 100% support people receiving opioid replacement therapy, which is known as Suboxone, or if you do it over, you can do now 30-day injectables at Sublocade. And they're doing this in Alberta, Canada right now. They're replicating this Dutch and Portuguese model. So, but I think that I'm also very concerned about us moving towards just a kind of hospice model, completely giving up on people. What we've seen now in Canada is that they've now opened up end-of-life care, assisted suicide to people without having terminal illnesses, and there's now a debate whether that should extend to people with addiction. So I worry about us headed down a road of basically enabling death more immediately than over the long term. I don't think we should give up on people. It doesn't mean we're going to have a 100% success rate, but I fear that that's what Housing First has been doing.
again, I was not only sort of astounded by some of the numbers that we are seeing, but really, when it comes to the numbers of overdoses, I was frankly astounded that that we kind of keep doing a lot of the same thing with some things on the corners that might be different, but we sort of keep doing the same thing and expect really a lot of different results. Frankly, whether that's in the province or whether that's in the country as a whole. And it seemed very clear to me that we really needed to think about systems-wide change. By the way, the last graph there showing that we are on track to outpace. I wish I could say it went down in that year, but it didn't. And so this is, when you look at BC and Canada, we're on track to increase. I think it's very concerning, and the numbers don't lie. When you look at the way that we are here in the province compared to industrialized countries around the world, various regions around the world, whether it's the Middle East, Scandinavia, parts of Europe, and even the United States, which is traditionally, probably the most famous book in drug policy is called The American Disease, and that was by the late Dave Musto at Yale. And it was because, unfortunately, America always had this badge of being the highest, usage in the world. We actually, that gold medal has been passed over to you all, and that's not one that any of us would wear with pride. That's one that should be a wake-up call. That doing the same thing over and over again and expecting different results is something called insanity, and we need to figure out what else we can do. And I think these numbers are pretty